A very good evening to all the viewers of today's podcast. I extend a very warm and a very heartfelt welcome to all of you to today's episode. My humble regards and great respect for Foxy President Dr. Sunita Tandulwadkar Madam, and extend a very warm welcome to guest of honor today, Professor Dr. Srinivas Gadappa sir. Today's episode number 294, and this is Star Gyan Pravah podcast. ज्ञान का बहता रोज एक अनोखा रंग हर रात 8 बजे आप जुड़िए फॉक्सी के संग. So when we say episode number 294, this is groundbreaking. This is something we can call a record. And this idea has been conceptualized by Foxy President Dr. Sunita Tandulwadkar Madam, who is a leader who leads by her example. We all know she's a great obstetrician, endoscopic surgeon, infertility specialist, and pioneer in regenerative medicine in OBGY. But we also know that she's a great spiritual inclined person and also a philanthropist. We have witnessed a very splendid, a very successful Star Sampurna conference recently under her leadership. And it was a beautiful blend of academics and very rich heritage and culture. So, Madam is known for her perseverance, dedication, 24 by 7 work, and her attitude that she never settles for anything less than perfect. So I'm learning a
Thank you,
lot from you,
Rashmi.
Madam.
Thank you. This
And it's a
podcast
great
is about you and Dr. Gadappa. Thank you.
it's a great honor
Thank,
to be part of your team, Madam.
thank you, Rashmi. And you are one of the most sincere and dependable chairperson I have. I'm very proud of you and all the chairpersons. Dr. Gadappa, welcome to the Foxy platform. This is again, I feel Star Pravaha gave us an opportunity to pull out so many people to work for a Foxy, whether for a few minutes or few hours or few days. But we could reach out and made maximum Foxians involved in various activities, may it be publication, may it be our evidence-based writing, or may it be through the podcast series. This podcast series is designed only for the chairperson. So on 18th of every month, the Rashmi comes. They work with so much dedication. No one has missed a single podcast. They never interchange among themselves also. They 18th means every 18th Rashmi will come. And this discipline gave so much of happiness for this Pravah series. It's running 294 today.
294th episode.
Yeah, so it's impossible to even dream of we did everyday podcast. And I'm sure, Dr. Gadappa, with you, this podcast will be one of the beautiful broadcasts to hear. Our protocol is I join the viewers link and listen to both of you. So enjoy. I join just to thank you for your time given to Foxy.
Thank you, Dr. Tandulwadkar, madam. Really, it is a very great initiative because all Foxians are linked to such important topics. And your initiative, like as you are all-rounder in all the subject, this is the really very good project. And I am very thankful that you invited me and I am humbled.
Thank you, sir. Thank you. Thank you, Rashmi. God bless you. God bless
Thank
you.
you so much, ma'am.
Thank you.
Thank you so much, ma'am. So it's a great honor for me to introduce today's guest of honor, Dr. Professor Srinivas Kadappa sir, to this podcast. As we all know, sir is professor and head of the Department of OBGYN, Government Medical College, Chhatrapati Sambhajinagar. He is pioneer in the work of respectful maternity care. It's an initiative in a government hospital he has taken in partnership with White Ribbon Alliance. Is a master trainer in gender integration in medical education. He has published groundbreaking research on internal iliac artery ligation in refractory pulmonary postpartum hemorrhage, and it has been published in a series which represents the largest series on this topic. He has received the prestigious Azim Premji Award for Best Practices and Integrating Gender in Medical Education. The case study is now included in the curriculum of Azim Premji University. last year in 2024. It's a thing of great honor that Chief Minister of Maharashtra has honored him for outstanding contribution to respectful maternity care in patient care at Chhatrapati Shambhajinagar Government Hospital. He has authored more than 103 national and international research papers, including significant studies on internal iliac artery ligation and quasi-practical model for respectful maternity care. He has authored a book on standard care, operating procedures, respectful maternity care. This is officially recognized by MUHS and Government of India, and best practices implemented at GMCH Aurangabad. They were featured in a coffee table book by the Maharashtra government, published by the National Health Mission of India in 2019, and has received several applauds. Is serving as a nodal officer for various government organizations, collaborated with WHO and SEHAT on a project focusing on healthcare responses to violence against women, which was published on the WHO website and has received commendations. Sir, with this short introduction, I welcome you to today's podcast. Welcome,
Thank you,
sir.
madam, for your
Thanks.
introduction.
So, sir, to start with, when we say we are interviewing or we are talking Professor Dr. Srinivas Gadappa, sir, three things come to our mind first. Because, sir, you are known for your immense work in respectful maternity care. You are known for your immense work that has helped in reducing the maternal mortality and morbidity drastically in the area. And you are also known for your various protocols applied in emergency obstetrics care, thereby saving the lives of the mothers. So, when we say respectful maternity care, sir, we understand by the word that it's a treatment given to a mother and a newborn with great dignity, compassion, and autonomy. But this is respectful maternity care is a long evolution process. It was shaped by culture, tradition, medical advances, social changes, human rights advocacy. So, absolutely previously, when the birth was mainly governed by customs, traditions, companionships, and compassion. Later on, medical advances took over, and this some in somewhat this compassionate aspect was compromised. Later on, the uh, institutional heads like you, they are trying to build, they are trying to bring out a balance in medical advances and dignified compassionate care in the form of respectful maternity care. So we all understand that this is a very long way. This was a very long evolution process. Because when we say this work, we instantly understand that the head of the institution who has implemented and started respectful maternity care must have worked so hard, must have given blood and sweat to set this system, because this is a completely different territory. It evokes an instant high respect for you, for your work. So I want to know, how do you implement this respectful maternity care in day-to-day OBGYN practice?
Yes, thank you, madam. That was a very good introduction you have given. The respectful maternity care, this concept came with the landscape published paper by Browser and Hill in 2010. And there he has published this paper by a multicentric trial, and it addressed the issues like disrespect, abuse, and loss of privacy in a tertiary care hospital, and how this has impacted the maternal morbidity and mortality. And that was taken up by WHO and White Ribbon Alliance. And then in 2015, the practices are propagated. So I was one of the obstetrician who has attended the WHO and SAID and White Ribbon Alliance initiative, where we were integrating gender in medical education. And there we come across this White Ribbon Alliance charter for women's right. And they have given different charter initiative where they have said what are the rights of a birthing woman. And those rights, when we have read, and the practice which we are doing was absolutely different, because the woman who is coming to the labor room at that time, in most of the institute, in my institute, she was kept in a labor room, She is alone. Nobody was accompanying her, and she was advised to take rest in a dorsal position. Delivery is always in dorsal or lithotomy position. Augmentation and all these things were there. So was those practices were wrong? No. Those practices were we are doing because at that time the maternal mortality and the neonatal morbidity and stillbirth was immense. So we were want to decrease these things. But as the mortality has not decreased too much, why? Because there was a fear in institutional delivery. Because there is disrespect and abuse which was there, which was normalized by the institute. Even as a resident, when you used to talk to the patient, we were little loud. Even the obstetrician who was there used to say that "मी तुला मोकळे करते थांब." So they were taking the responsibility of delivery. But the respectful maternity care made the woman, empowered the woman for delivery. We are just assisting her. So this is not new. It was actually there in old heritage days also. But the White Ribbon Alliance and the evidence which has come that has showed that this is very important. And then we started implementing this. It was a big challenge to put those 7 rights which were given. Now the White Ribbon Alliance has made it to the 12 rights. So 7 rights, that is privacy, disrespect, abuse, consented care, and all these things were there. So putting this charter is also a challenge because people said that we are not practicing this. If we allow a birth companion inside the labor room, then it will lose the privacy. But all these challenges were possible when we have primarily done a proper training. And we are very fortunate to undergo training with the WHO and the White Ribbon Alliance. And then the things are started implementing. Initially, it was very difficult when I have started implementing. But as the training goes on, the training started with showing the videos, started with the playing role play, showing the evidence which is practiced in the Western countries. And gradually, the doctors, the residents, the faculty, staff member, even the supporting staff security, all are involved. And that has given the result that today is the highest institutional deliveries, highest patient referral center, where we deliver around 60 to 70 deliveries, means 3 deliveries in hour. And we are having a good maternal and fetal outcome.
Thank you, sir. So, with this, we understand that there is equitable access to evidence based care because we have created this system when we say respectful maternity care, where the justice to the patient is also done, there are no moral injuries, and highest possible medical care is also given. But this must have taken a lot of time. The system creation and setting the system must have taken a lot of time. But once it has been set, for example, at your institution, now you must be following it with some protocols to curb the maternal mortality also. So has this protocols help in decreasing the maternal mortality also and neonatal mortality and morbidity also, and how it has happened?
Yes, that is the crux of implementing respectful maternity because it is not only the concept of respect and privacy, but it is a practice of evidence based medicine. And we are very fortunate that in labor room, when a woman is coming and they are having severe mortality due to hypertension, hemorrhage, sepsis, and all these things. Initial days, there were some treatment modalities available, but there were not proper guidelines. But now we are dealing with a standard operating procedure for everything. For example, you think of a hemorrhage, think of a preeclampsia, think of a sepsis, or comprehensive abortion care. We have got a bundle approach. In those days, if a PPH comes, there was algorithm that you give massage, you explore it, give methargine, pitocin, prostadine, and there was no clear-cut guidelines. But a PPH bundle approach saying that simultaneously treat everything. Golden hour, which was in theory, now we are not only practicing, but not only preaching, but we are practicing. So the bundle approach of PPH, bundle approach of preeclampsia, bundle approach of severe hemorrhage, and bundle approach in sepsis. These evidences are put in the SOP. If a woman gets severe morbidity or she suddenly collapse, how to manage? Everybody knows that sudden collapse. But in the institute where you are working, there is a specific protocol that are 10 to 11 residents are working in labor room and one woman collapses and there are another 20 women in the labor room. So these SOPs are going to tell you that who is going to take over, who is going to be a champion, who is going to follow the protocol. So there is no ambiguity, no confusion, and who is going to treat the patient and who is going to talk to the patient, and the involvement of the patient and their relatives giving a good outcome. And there is no any havoc or any assault in the labor room, and the woman is going happily with the mother and the child.
So this is very important. This is very impressive, sir. So just when you detailed about PPH, for example, bundle approach. So one part is setting the system, one part is achieving a delicate balance. Now, see, for example, sir, we want there are two sides of this spectrum. We have to take the consent. We have to avoid unjudicious use or unnecessary procedures on the patient in respectful maternity care. But at the same time, we also have to deal with this high demanding emergency. That is the patient who has collapsed due to PPH, for example. But head of the institute, for example, sir, do not only have to see that you are teaching or making your students learn about how to handle these things, like what is the PPH bundle, what is the what has to be done. But you also have to look into the matter, like for example, a patient's need non-pneumatic anti-shock garment, for example. It's available in the institute. So for example, we see many institutes, they teach, they know the things, but the availability also matters. So for example, all the equipments and all the things needed to follow these protocols that are available, this is also something the head of the institute or the person who is head there, main there, has to look after. So we understand that this is a great work, this is a work totally in depth. So what do you say about this, sir?
Yeah, because when we talk about these things, actual implementation is very important. And not only implementation, sustainable is another thing. Third thing, implementation and sustainability will be only available when you do a continuous monitoring. As you have said that in bundle approach, we have got NASG, we have got uterine tamponade, we are oxytocin, we are having newer drug like carbetocin, all these things. So they should be available. So in our department, we are having a unit system, and as everybody has got WhatsApp group, every day in morning in WhatsApp group, when a new unit takes over, he puts on the photograph that NASG is available. If it is applied to another NASG is available. All oxytocics are available. UVT balloon is available. So all these things are checked. So that is the checklist we are preparing. So if I am taking over at 8 o'clock, all my residents, assistant professor, they will say that all things are available and they confirm when patient is correct. Then PPH box, sepsis box, eclampsia box is available and full. So this is all things are done checklist. Secondly, if some serious patient comes, immediately it puts on the group that some serious patient is coming and we are treating. So the person who's on floor, for us, there is a conducive environment is important. Because if a doctor is healthy and doctor is happy and he is having proper diet, he can work. So the principle of our department is that if you feel unhappy, if you are ill, and if you don't want to work, the casual leave is immediately given. They are not stopped. But once you are working, it is supposed that you are working a nanosecond, they are not excused. So I always say in labor room also, in OT also, we keep all the lights on because every 20 minutes one delivery is occurring. So there is no any illuminated area. CCTVs are there in the corridors, and every minute progress of the patient is put in the WhatsApp group. There are CTG machines to monitor intrapartum care of the babies, and that CTGs, wireless CTGs, where CTGs are directly seen by the consultant and the professor. So we know that which patients are we are starting induction, how the CTG is going on. So neonatal care is taken. Then patients, most important thing is that our anxiety, it has to be relieved. So birth companion. So we are allowing the birth companion. Means either her mother, her elder sister, of some relative who has got an experience of delivery. So she is allowed inside and they are not allowed in antenatal clinic. They are given a training if they know that who are going to accompany. If they are coming on emergency basis, a short poster is there outside the labor room where we are supposed to tell them what a role of birth companion. Definitely, she is not going to interfere in other patient because everybody is birth companion. But what she should do, how she should take her inside, how she should mobilize her, how she should give massage, how she should help her in giving different birthing position. Because this birthing position is a component of respectful maternity care and SOP. So all the pregnant women who are in labor, they are given different charts are there in the labor room. They are given different birthing position because the traditional method of dorsal position and lithotomy position, absolutely it is very less now. Because if you leave the woman liberally anxiety free, she takes different position. So what position she take lateral position, she takes 4 point position, she takes a sitting position, she takes upright position and squatting position. So we are asking her to take this position. There is a squatting bar which we have invented and we have put on our normal birthing beds. So it is not that delivery should occur on labor table. Delivery can occur on normal bed also. There the squatting bar is given. She's taking that support and using different position. Just she is seeing the picture and she is taking her own positions also. And that is giving her anxiety free environment. That is giving her no need of oxytocin and the visotergo action. Means head is down, patient is in upright position. So three things are occurring: the uterine contraction, gravity, and bearing down efforts. So this is called obstetric shoot, and that is giving a natural way of delivery, minimizing the rate of cesarean section and even episiotomy.
So when talking about the cesarean section, we now know that there is increasing trend and the increasing trend in placenta acreta spectrum cases also.
Yeah,
So I know personally that you also have developed this protocol for management of these cases. So and it is multidisciplinary. So for audience, sir, would you like to tell us about this um,
agree.
multidisciplinary protocol for the
Yeah,
management of placenta acreta?
because nowadays the cesarean section rate is increased. The reason is different. We are not going to land in that controversy, but the woman is suffering. Why woman is suffering? Because the rate of cesarean is increasing. One, two, three cesareans are increasing. Then the protocol for suturing uterus, everybody has got different protocol. So exact reason is not known, but the placenta is being adherent to the scar, and we call it the accreta. So accreta patients, when they are coming to our hospital, they are coming from periphery. Most of the powerless women, they don't have money also. So the treatment modalities which are told that angiographic embolization and all these things, they are not affordable. Multidisciplinary approach like urologist and they are not available everywhere. So our department, all the unit in charges, they are trained and we are managing minimum 2 to 3 placenta accreta every 15 days. So for example, tomorrow also we are having accreta. So we have designed our own standard operating procedure which will suit to our periphery. So the first concept is that when accreta comes, all unit in charges, they will come in the OT. So it is a surgery of senior and the assistant professor SR will assist. There is a protocol for massive transfusion protocol because most of the time blood transfusion availability is important. So that is assured and we keep all the blood transfusion 1:1. Secondly, what to do with the placenta. So placental mapping, rescoring of the placenta on ultrasound. Even as an obstetrician, we also do it and we see the extent of placenta. Most of the placenta accreta which we are coming across, it is a placenta percreta or sometimes into the bladder. So such patient require caesarean section from a classical incision and the hysterectomy. Very few patients undergo conservative surgery. Most of the patient they require hysterectomy. So it requires a proper approach, classical incision on the fundus of the uterus, deliver the baby, don't touch the placenta and start hysterectomy. There is a lot of controversy by some of the stalwart. They say that no, I do all placenta accreta and I have got a conservative management and uterus is saved. But personally, our experience, whatever we have published, conservation is required only in 10% of the patient. That is focal placenta accreta. Most of the placenta accreta now they are global and they are percreta. So conservative approach can cause massive blood loss and patient can have severe morbidity. So caesarean hysterectomy we do, massive transfer protocol we do. We take the involvement of multidisciplinary approach. We get good anesthetists, good intensivists, and ICU measurement. Because the ICU availability assess most of the patients, 60% of the patient, they require post-operative ICU care because of massive transfusion protocol. So that is a team which is comprised of obstetrician, comprised of anesthetist, neonatologist, sometimes surgeon, urologist is not available. So we manage all these things and the woman go happily with the mother. So
So
this is
this,
all team approach, and the protocols they are written on the paper, and they are stick in the OT, that who is first surgeon, who is second surgeon, two section machines, who is going to take photograph, who is going to do video shooting, who is going to take look after the consent, and who is going to talk to the patient and the blood bank. So everything occurs smoothly and the woman is safe.
yes, yes. So, and another giant killer is hypertensive disorders of pregnancy.
Yeah.
So, we need to diagnose these cases early so that we can prevent complications arising out of it.
Yeah.
So, what would you like to suggest over early diagnosis and prediction
Yeah.
of these cases?
Because we used to strive hard to treat the patients of PPH. Now we have almost conquered the PPH in most of the cases, and the mortality which we are facing in our maternal death surveillance response is a preeclampsia. And why they are dying? Because they are coming very late. They are throwing convulsions. They are coming with HELP syndrome. They are coming with DIC, IUFD, and abruption. So, as you already rightly said, that early detection is very important. So, how early? So, I think it should be in the first trimester screening. So, uterine artery Doppler, PI, and Gestosis score, designed by our own Foxian. These are very important. These are simple things. Uterine Doppler does not require investment. Gestosis score does not require investment. If she is on high risk, you must put her on aspirin. And we have decided that aspirin 150 milligram after 12 to 16 weeks, ideal time to start low dose aspirin for prevention of preeclampsia. So early detection with available modality. So at the periphery, you cannot do uterine artery Doppler because there is no ultrasound facility. And even if it's there, the person is not trained in that. So what you can do is Gestosis score, and you can see the high risk factors. If the gestosis score is coming more, always put her on aspirin. But unfortunately, few women are getting this. Most of the women are directly coming with severe preeclampsia. So our aim is to that. Secondly, in our department, we are doing all these things. We are training the woman and their relatives for blood pressure monitoring. We are asking them that you are, because they used to do ultrasound so many times outside, and then they are coming. So we ask them that if possible, buy one ultrasound. No, the one's BP apparatus, that is NIBP. It costs hardly 1500, and we train her and her relative, and they keep on recording. So most of the book patients are detected earlier, but unfortunately, at the periphery, due to the lack of access, the woman is not coming because the community participation is very less. Because the health system, public health, the medical education is striving hard. They are taking repeated meetings, MDSR meeting to decrease maternal mortality. But the community is not participating. And there are cliff trial on this where community participation is required. They should be made aware of the signs and symptoms of preeclampsia. They should be trained to do take their blood pressure and early warning sign, definitely that will decrease morbidity and mortality. For example, if a patient comes with severe preeclampsia, giving her magnesium sulfate 14-gram loading dose is must. It should be trained to everyone. That's why the public health and government of India and medical education took the Lakshya program under their thing. Under this Lakshya program, they conduct different BMOC training, basic emergency obstetric care, where few things are taught. For example, how to treat hemorrhage, how to give oxytocin immediately after delivery, how to give magnesium sulfate, how to try antibiotic in sepsis, catheterization, manual removal of placenta. So these seven obstetric skills they are trained in BMOC, and that's why we are achieving decrease in maternal mortality.
So, at our institute only, how can we involve or train more of our healthcare workers, the nursing staff especially?
Yeah. So because as an obstetrician, we are doing best. Our Foxy is doing very best and taking so many conferences, so many guidelines, involved with all different bigger agencies. But as you rightly pointed, that midwives, healthcare providers, and medical officers. So medical officer they are treated by under Laksh by BMOC program, and the training program is going on, and public health is very much aware, and they are rigorously training them. The midwives or the staff nurses which are there, they are also having their different conferences, and each department is training them every year. For example, at our hospital, we have got a renaissance. That is, every year we publish whatever happened in last year, and we trained the newer resident for 15 days along with the staff system. So everything, whether it is the management of obstetric disease, whether it is RMC practices, they are trained again and again, and monitoring is done. So only training. monitoring, giving incentive for good person, creating champion can decrease mortality, and that is we are doing.
This is immense hard work, sir. No doubt about it. And most of the time, for setting this system or this protocol based system, so most of the time, most of the physical presence is also needed. Say, for example, we can say timing of clamping of cord and cutting of the cord could be a trivial thing. Or, for example, to initiate breastfeeding of the newborn, skin to skin contact of mother and newborn is something trivial. But when we start implementing all these things, the head or the main person has to give so much time. Literally, his physical presence is important at the initial attack or at the start. But later on, once the system is set, the students, especially those who are um, studying obstetrics and gynecology, they watch, they observe, and they go through this process. They understand the importance of equal importance of taking the care and also a compassionate attitude, that is respectful maternity care. So it must be affecting or influencing the students in a very positive way, because this was not something there at the time when we were learning, and now the students, they have exposure of this respectful maternity care, how it has to be implemented. So how do you see the difference on the students especially, sir? Uh,
Yes, because decreasing maternal mortality, giving good clinical practices is not one man's job, and that is not sufficient also. So today I am very happy that even if I am not there in the department, my department is so trained that the last resident in the department know what are the different practices, and they teach each other. So peer teaching is there and continuous monitoring is there. For example, in our days, we used to deliver the baby and put upside down baby. But now, when I go in the labor room, I see that the residents are putting baby on mother's abdomen, waiting for that cry, and they are clamping and cutting the cord after 3 minutes. I think it is a big achievement, which was not there. And they are training each other. So JR1, JR2, JR3, and the on-floor assistant professor, lecturer, unit in charges, all are so much trained that today, even if I am not there, the things are going to occur, and these practices are documented daily. And there is a monitoring and audit going on for episiotomy, for cesarean section, for morbidity. So the practices are continuous. So I think continuous monitoring, then statistics, then audit, that will create the practices continuously go on. I identifying champions. So if some sister is doing a wonderful job, she's giving a breastfeeding, she's showing the breast cord, or a student has diagnosed PPH immediately after cesarean section or normal delivery, and he's treating with a bundle approach, we applaud, we acknowledge, and we declare them champion, and the practices go on.
Yes, sir. So, sir, are there any other clinical protocols also you would like to stress or tell us about, apart
Yeah,
from this emergency medical obstetric care?
yes, the most important thing that if you want to decrease morbidity and mortality, so we must have good antenatal care, intranatal care, and postnatal care. So we have got all these protocols. For example, a woman is coming with a pregnancy in our antenatal care. In the first block only, we have got IC material where we have written whether this pregnancy is wanted or unwanted. Because most of the women with pregnancy, when they come to us, they may not be having a wanted pregnancy, but because the in-laws have sent her, so she's coming to antenatal. So there is a big board with IC material where they can decide it is a wanted or unwanted pregnancy. If she's unwanted pregnancy, she is concealed and she has given a comprehensive abortion care. And in comprehensive abortion care, we see that if she requires abortion in first trimester, she should be given in first visit, at the most second visit. If she is coming with mid trimester, we are unnecessarily not conflicting her with a sex selective sex abortion. If we find that MTP was delayed due to different reasons, because there is a lot of gender operating going on abortion, so we offer her mid trimester abortion without bargaining with contraception and sterilization. So that is the first thing. Secondly, if it is a wanted pregnancy, then she goes inside, and first thing she come across is the ICTC counseling. That is HIV and all these things. So proper counseling is done if she is winning or she is tested. Then she undergo antenatal registration. Then she undergo gestosis score screening. Then she undergo GDM screening. Then she is given different immunization and then obstetric examination, then counseling for nutrition, safe delivery, birth companion, and all these things. And then she take the tablets and then she go home. So such a wonderful antenatal clinic is opened in the Chhatrapati Sambhajinagar, which is recognized by NHM. Many people come and visit it, even by WHO. So this is one that there is a protocol for proper antenatal care. Then these are the some screening tests like Doppler, PI Doppler in first trimester, then SFLT and all these things. So these an anomaly scan. This is a special table reserved there where the women who are ISRIC, they are specially concealed and they are offered services free of cost. Not a single tablet is given from outside. So this is one protocol. Secondly, we have got a protocol for violence against women. Means most of the women they suffer sexual violence, they suffer domestic violence. So in the antenatal, even if the pregnant woman comes, she is given a confidentially inquiry, and we use a lives approach: listen in sensitively, ask question, inquire, validate, and NR support. So we do that. And the woman who is having sexual assault, she is given a separate confidentiality room that we call Sukun Kaksh, where she properly examined, and if she's unwanted pregnancy, we give that also. Then there is screening, and the women who require admission, they are immediately taken to the antenatal ward, and it should be always accompanied by a doctor. So immediate treatment is started, and proper counseling is done, and we give them a different protocol management. So that is what we are doing.
So in most of the cases, there is also involvement of some non-clinical component, maybe transport, maybe ambulances, maybe the long
Yeah.
distance when it comes to emergency obstetrics. So can we go to the community and how we can do awareness programs for the community or the common people regarding the same? Can we do it?
Yeah, in medical education, that is the big hazard, hurdle, because we cannot reach up to the community. But what we do on in Chhatrapati Sambhajinagar, that we have got some collaboration with the NGOs. For example, some days like now we are celebrating Eklamsha Day. We are celebrating different immunization day. So we take some community participation program in the our outpatient department. But there are certain organizations like M Mitra. There is a newer organization called Kaleidoscope and White Ribbon Alliance. Here we go at the community. So we there are some defined community and we tell them. Secondly, how we have got a social service superintendent. We call the community leaders because most of the community leaders, around 80%, they call us for any patient. So we take a repeated meeting. If a complicated patient comes, we make them aware that in your hospital, in your area, this hospital is there, and we want that we should change this thing. So that person goes and inform them. So as a community participation, we take help of the leaders to educate the community, and sometimes then they organize the some function and they call us to address certain things like anemia, antenatal care, HPV vaccine, and we do that.
So this is very great discussion going on, sir. We have time constraints, but uh, it has been a great honor to discuss with you about all the respectful maternity care and measures you have taken for our emergency obstetrics care to reduce the maternal mortality and morbidity. The work is immensely impressive. Would you like to give us a final message for our audience regarding
Yeah,
the
the final message is that our aim is to decrease maternal mortality. Though Maharashtra is second in decreasing maternal mortality, we are having 33. But still, we want to prevent preventable mortality. So we are not delivering the baby, but we should deliver a care so that woman will be saved. I think that is my message.
So, thank you so much, sir. This discussion will go on because the topic is vast, but we have time constraint. I'm extremely thankful to you for your time, and it has been a great honor to be in discussion with you today, sir. Thank you very much.
Thank
Thank
you,
you.
madam. Thanks a lot.
Thank you, sir. Thank you very much, technical team.